Okay. So good afternoon, everyone. I think Happy New Year to all. This is the first meeting of this year 2025. I think we hope that we'll be having the same zeal and interesting cases are to presented in our monthly meetings. So I think Swati is on the way. She is coming from RML, so she will join soon. So meanwhile, we'll start because we are already late. So for the first session, I would like to welcome Dr. B. Gupta sir to chair this session, and Dr. Lalit is he here? Yes. Sir, sorry, sir. Thank you for coming. And I think we'll start with two cases. One is Dr. Anurag Agarwal. Dr. Agarwal had done a very wonderful workshop on focus. You all remember him. We had midterm in nephrology midterm conference, and focus was actually very cases here also. So I said, okay, we'll invite you. So we are honored to have Dr. Anurag. He is a director and head of department at Mercy Medicine at Hotel. He's having his pain medicine department as well, and he's doing a lot of pain management. And I think we'll have your case, and then we'll have discussion. Dr. Anurag. Thank you. But Bigger, what would like to say something? We are live on YouTube, right? No.
Good afternoon and Happy New Year to all. I think this chronic pain is really chronic and very painful and very difficult to manage. These both conditions, this hepatic neuralgia, trigeminal neuralgia, they are really painful for even the neurologist. And we always seek the support of pain specialists, and Anurag is my pain specialist.
Thank you.
So I refer all my patients to him for last 5 to 10 years. So it's Anurag, have you.
Thank you, sir. Thank you so much. I was not knowing that sir is on the dais. Otherwise, I would have changed the presentation a bit. But anyways, I will like this presentation is just to give you an overview of how a pain specialist can help when the pains are not getting managed by medical means. So any questions you can interrupt me in between. I will be glad to answer if I am able to. So like these cases, post-herpetic neuralgia, this is quite common with the availability of vaccine now. Maybe we'll be seeing less of these herpetic neuralgias, but even in young populations like 40 years and above, these are very common. And sometimes even with best of the treatments, antivirals, the pain doesn't get better. So a bit of epidemiology that this is the definition is post-herpetic neuralgia is when the pain persists in a dermatomal pattern even after 3 months of herpes zoster viral eruptions have healed. Okay, subacute will be 1 to 3 months, and approximately 9% to 34% is the data that these patients will suffer from lifelong chronic post-herpetic neuralgia. And the signs, if you will see this patient, always check for signs. These patients will have evidence of cutaneous scarring, altered sensation, either hypersensitivity or decreased sensation. Sometimes these patients जैसे blouse नहीं पहन पा रहे हैं, ठीक है सर, कपड़ा भी लगता है. So these problems are quite common. And in patients with herpes of the upper limb and lower limb, you will see some patients walking with difficulty in walking because the motor nerves are also involved. So कई बार differentiate करना मुश्किल होता है कि ये disc related problem है या ये herpes की वजह से dorsal root ganglion जो involved हुआ है या motor nerves involved हुई हैं उसकी वजह से weakness है. So treating shingles early within 3 days of developing the rash and aggressively with oral antiviral drugs reduces the length and severity of post-herpetic neuralgia. So this is very important. Antiviral drugs, we have 2 drugs most commonly used. One is valciclovir 1 gram TDS for 7 days, or acyclovir 800 milligram 5 times a day for 7 to 10 days. And the pathophysiology of post-herpetic neuralgia is that there is acute phase of herpes zoster, inflammation of the nerves, stimulation of the sympathetic nervous system, reduced intraneuronal blood flow, and then leading to neuronal hypoxia and entoneuronal edema, which leads to damage to the peripheral and the central neurons. Then there are formation of the connections between the sensory system and the sympathetic system, leading to inappropriate activation of the primary nociceptive fibers. Also, damage to the peripheral and the central nervous system leads to development of low threshold action potentials which discharge spontaneously. So these patients will have hyperalgesia and allodynia. Even in the autopsy findings, people have found inflammation on the DRG, peripheral nerve, spinal cord inflammation, and accumulation of lymphocytes. There is presence of fibrosis, myelin loss, atrophy of the dorsal root ganglion in the affected peripheral nerves, and fibrosis of the large inhibitory nerves. So this is all the. So when it comes to the pain management, which is our case, the pain management depend on the severity and the location of pain, age, comorbs of the patient, medication side effect profile, treatment and the cost and the availability, and the patient values and preferences. So the medical management remains the same. We all know that the neuropathic pain medications, there are only 4 medications which we commonly use. We don't have the 5th or 6th. And apart from that, lignocaine patches, topical capsaicin play a vital role. NSAIDs and opioids play a supportive role. So coming to lignocaine patch, 5% is available. Each patch has 700 milligrams of lignocaine. A portion or up to 3 patches can be applied simultaneously for 7 hours, and after 12 hours you have to remove it, and the effect will last for 24 hours. The mechanism of the patch is believed to be the reduction of the aberrant firing of the sodium channels on damaged pain nerve fibers directly under the patch. And adverse effects are not commonly seen, usually not seen. Topical capsaicin is also very important. In India, we don't have capsaicin patches, but we have some ointments which have capsaicin up to 0.2025%, commonly like Volitra, and these have capsaicin. So instead of using the normal painkillers, we can combine, usually Sir also combines lignocaine with capsaicin, and this also helps the patients. Okay. Antidepressants, we have the antidepressant class of neuropathic pain medications, which is amitriptyline, nortriptyline, desipramine. Then duloxetine, pregabalin, in the number needed to treat is one of the definitions how we choose our medication. So number needed to treat is after, like if the NNT of duloxetine is 3, it means that in if I give duloxetine to 3 patients, one of them will get better. Okay, dosage is also important, and NNT is also important. So it has been found that duloxetine and pregabalin has the best NNT when it comes to managing the post-herpetic neuralgia. So usually the patients on an average requires at least 150 milligram to 25 milligrams of pregabalin and 60 milligram of duloxetine. This is the usual dose which I have felt is required. Lower dosages do not help when it comes to severe PHN, established PHN. In acute phases, you can do with low doses. Then comes to gabapentins. Other anticonvulsants may be required sometimes, especially when there is a facial CRPS, because the amount of sodium channels which is on the face is large. That is why in even the trigeminals, carbamazepine is the drug of choice. So when it comes to herpes of the face, usually carbamazepine or oxcarbamazepine gives a better result as compared to other drugs. Opioids, I want to say this is a very busy slide, but I just want to say that combining opioids is not a good idea. Many a times I felt that somebody has applied a buprenorphine patch, over that patient is been given tramadol also. Somebody has given tramadol with morphine. So combining 2 opioids is not a very good idea. Opioids, the issue is that when we give buprenorphine like drugs, which are agonist antagonist drugs, they have a strong binding to the opioid receptors, and they have low intrinsic activity. Buprenorphine is a drug which is given in patients with opioid abuse. Okay, so if you give buprenorphine, over that you give opioids, those opioids will not act. Okay, so when you are using strong opioids like fentanyl or morphine, never combine them with agonist antagonist drugs. Okay, if you are giving tramadol, better to give 300 milligram. If it is not working, go to the second higher opioid. But usually it is not recommended to combine 2 opioids. Patches are also available, but how long you will give strong opioid patches, because these are expensive. Fentanyl patch usually costs around 500 rupees. 600 rupees is the minimum of 25 microgram, and how long you can keep applying it. So this is not a very good idea. Usually for short-term relief, we can use patches, but not a, then if, this table also tells us that like when I have to titrate, a patient comes with severe pain and the patient is not affording the interventions, and you have applied 25 microgram patch to the patient. So patient gets good relief. Okay, now you can convert this fentanyl to morphine. So 25 microgram of fentanyl is almost equivalent to 60 milligram of morphine or 50 milligram of morphine. Morphine is very cheap. Whole month cost will be 500 rupees. So you can convert that 25 microgram of fentanyl to morphine and give good relief to the patient. So this is how there is opioid conversion also. You can see how much opioid person is taking, like patient is taking 300 milligram of tramadol or tapentadol, and you have to convert it to fentanyl and morphine. So there is opioid convergence. So instead of titrating the dose, you have already given one opioid, better to start from there only and give the best doses possible on the first attempt rather than titrating every time. Now, this was my paper. I presented a meta-analysis on post-herpetic neuralgia. This was a systemic review of current interventional pain practices. So 20 years data I compiled and presented that what are the best interventions which are helpful in managing post-herpetic neuralgia. So this was published in 2020. So interventional strategies when it comes is we have peripheral nerve blocks, we have sympathetic blocks and neurolysis, epidural and intrathecal methylprednisolone, pulse DRG RFA, conventional RFA, and spinal cord stimulators. We usually don't go in India to spinal cord stimulators. It is a very expensive therapy. Around 7 lakhs is the cost of spinal cord stimulator. And it is just like marrying a person when you put a spinal cord stimulator. So in India, I usually have not used it, but in Western world, I had put spinal cord stimulators in NHS when it was free of cost. Okay, so coming to the facial pain. If it comes to facial PHN, what you can think of? The simplest way is to, if this is a forehead, supratrochlear and supraorbital nerve blocks. Okay, you put 20 milligram of Kenacort with 1 ml of lignocaine or bupivacaine over the supratrochlear supraorbital nerves. This will lead to the stabilization of the myelin sheath. Okay, the local anesthetic only works for few hours, but the steroid which you have put, it decreases the inflammation which is occurring, the local inflammation, as well as it stabilizes the myelin sheath. So it usually a patient who is in severe allodynia, you give this block and you ask the patient to come after 15 days. If the pain subsides, you can repeat it after 15 days or 1 month. 2 or 3 times if you give it, usually the pain will subside. And the severity will at least come down and your medicines will also start acting better. Then comes the there was a presentation which I made when I was thinking that when the supratrochlear supraorbital nerve blocks do not work, what is the other pathophysiology is leading to such severe allodynia? So the other concept was the sympathetic nervous system activation. So you can take park this severe allodynia as a CRPS of the face. Okay, so it is not only the sensory nerves which are affected, it is the connection between the sensory and the sympathetic nervous system which is getting jeopardized. So in this case, along with the local anesthetic blocks, you can also target the stellate ganglion, which is the sympathetic supply of the face. So if you combine these two, sometimes the patient who is not responding to the local blocks, they start responding. And the last is, even when nothing works, just ablate the nerve. In that cases, we usually use radio frequency ablation. In 1 or 2 cases, when I started using phenol and alcohol, it leads to lot of trouble. The problem is this is a very lax area. The phenol and alcohol, they trickle over the eyelid. Okay, there is edema of the both eyelids. So never use alcohol and phenol on the face, at least on the forehead. Use a radio frequency ablation, which will give a target lesion of around 1 centimeter. Okay, this is how we usually put. That's a very simplest block, no complications. Okay, and there is a lot of publications, and they have said that even when the patient is having a acute facial herpetic eruptions, and we start managing the pain in the acute phase, either by medications, if medication not work, start doing intervention in the acute phase only, so that the patient doesn't develop a PHN. So these are meta-analysis, and they have good amount of evidence. Level 1B evidence is there of the stellate ganglion block. Stellate ganglion block in acute PHN. Okay. And then a local triamcinolone injection for treatment of PHN. This also 1B evidence. So whatever we are doing by the book, evidence-based medicine. Coming to the intercostal neuralgias, very common, thoracic. Okay. When thoracic dermatomes are involved, target the dorsal root ganglion of the same level. So D8, D9, D10, D11, D12, these are the common dermatomes which are commonly involved. You can give a rib block also. You can give an intercostal block. If intercostal block doesn't work, you can go to dorsal root ganglion. Okay, so that works better than intercostal block. So you have to see the patient in total, what is the duration of pain, what all interventions have been done before. But these are very simple procedures. Okay, these are the patients. Now, if a patient comes with a herpes of the limb, lower limb, then the thing is that the motor nerves are involved. It will be L4, L5. In those nerves cannot be ablated. These are motor nerves. Patient will have weakness. In those cases, instead of ablating the dorsal root ganglion, what we do is pulsed DRG, pulsed RFA. Pulsed RFA, we heat the dorsal root ganglion for 2 minutes at 42 degrees Celsius. This leads to inhibition of the ectopic foci, okay, which is there at the dorsal root ganglion. So this is how under fluoroscopy guidance, we do these procedures. Okay. And thoracic, where you can see the dorsal root ganglion, the dye, which is going medial to the pedicle in the epidural space. Okay. So this is how targeted interventions are done. Okay. So this was about the herpes. And I think if any questions we can take in the last. Comes to disc problem, very common problem with prolonged sitting. Everybody is having some sort of a back problem, and this is one small case. 24-year-old female coming with severe pain radiating to the left lower limb, and after 3 weeks of bed rest, NSAIDs, still no relief. Patients got physiotherapy done, no relief, and MRI was done, which showed a L4-5 disc problem with left L5 root compression. Okay, so this was a small disc. Okay, you can see, you should start reading the MRI yourself, because that is better than reading the reports. In every report, you will find mild disc problem, mild disc problem. In 90% of times when it is written mild, it means nothing. Okay, so better to start reading the MRIs, then only you will be able to correlate the clinical features with the actual problem. So in this problem, you can see the lateral recess, paracentral disc is there on the left side. And now the patient comes to us, and patient, the studies are getting affected. Patient is depressed whether I have to go for surgery or not. So in these patients, mostly transforaminal epidural steroids, epidural neuroplasties, they are very simple procedure, 15-20 minute procedure. They will give good relief, lifelong relief to patients. Why I say lifelong, I will tell you. So after few days, the patient's walking distance for more than 700 meters. And this is how we do a procedure. Okay, we target again the dorsal root ganglion. Below the pedicle we go, fluoroscopy guided. We place the needle, put a dye, and see what is the dye spread. The dye spread has to be medial to the pedicle. Okay, and lateral view. So now when it comes to the literature, it says that only 77% of the patients in the group that received lumbar epidural steroids, 77% of the patients avoided surgery. If I am able to give relief to the patient for 1 year, 90% of the times patient will never require a spine surgery, because the disc automatically gets regressed. Okay, it is a time-taking phenomenon. When you are in acute pain, you will run for surgery. कि यार lifelong के लिए ठीक हो जाए, surgery करा लेता हूँ. लेकिन surgery भी lifelong के लिए नहीं होती. There are only few indications when surgery is needed. Okay, the first indication is terrible pain not relieved by medications or by interventions. Second is when there is a bowel bladder involvement, there is a cauda equina. Or third is when there is a weakness. Or fourth, I will add, is when the expert is able to read the MRI and say that this is not going to get better over time. Okay, if it is a bony compression, it will not get relieved. If it is a disc only which is compressing, there is a predictive value which is available. Net, you can see there is a predictive value that this disc will regress or not. Okay, so we can predict seeing the MRI. These are other reports that the conclusion of this study was that transforaminal epidural steroid injection reduces the radicular pain, improves the walking and standing in patients with degenerative lumbar spinal stenosis. But the problem in lumbar spinal stenosis is this is a bony stenosis. Okay, the bony stenosis will not get better over time. It will worsen over time. So if the patient doesn't want surgery, he has to come for epidural every year. Okay, or maybe every 9 months. But in young patients where there is no bony stenosis, no ligamentum flavum hypertrophy, only disc is protruded, these problems will get better with time if the pain is managed correctly. So this was the basis on which I was saying that this can give you lifelong relief, because these studies say that spontaneous resolution of lumbar disc herniation, predictive signs of prognostic evaluation. Okay, how I can predict that this patient will get better. Extruded disc, pain relieved. Extruded disc will vanish in 6 months time. Okay, when you see, this is only 3 studies which I have quoted, but there are numerous literature where they have shown the MRI 0, and then after 1 year, after 2 years, and you will see after 2 years the disc which was extruded has gone. That is why when I give pregabalin or gabapentin, the inflammation goes away after some time. I don't require pregabalin for 2 years. After 2 months or 3 months, the pain subsides, because the dorsal root ganglion is now not firing. Okay, and usually if pain recurs, I again give for 2-3 months, and after 2 years, maybe the patient will not come to me. It is not that pregabalin has got done the trick. It is that the body has the healing powers and it will cure the problem. So you should, if you are able to read the MRI, you will be able to guide the patient right. Last case is trigeminal neuralgia. Very big problem, suicidal disease. I usually see lot of cases of trigeminal neuralgia. My simple treatment of trigeminal neuralgia is medications. Medication doesn't work, young patient, go for surgery. Okay, but the problem is when you do go for a microvascular decompression surgery, it is an excellent surgery. I will discuss some of the things of the surgery also. But when I was an anesthetist, I was a neuroanesthetist, and I used to see the microscopic picture of the brainstem. Sometimes it is very difficult to differentiate the 5th nerve complex from the 7th nerve complex. Okay, many times the surgeon will put a Teflon in the 7th nerve complex instead of the 5th nerve complex, and after that the patient in the post-op will have the terrible same pain, and they will say the MVD has failed. It is not the MVD which has failed. It is the wrong area where by mistake the Teflon has been put. Okay, there is a neurovascular conflict. So even the surgeries fail. There is many cases I have done of patients where young patients MVD surgeries have failed. So let's discuss about the treatment ladder. First of all, the diagnosis: paroxysmal sharp shooting pain that is characterized by exacerbations and remissions. Pain that follows the distribution of trigeminal nerve. A normal neurological examination that includes no significant loss to facial sensations. MRI of the brain that demonstrate neither mass lesion nor demyelinating plaques, and pain that is induced by cutaneous stimulation. Every point is very important when you make a diagnosis, because there will be a lot of cases of TMJs, atypical facial pains, where people have made a diagnosis of trigeminal and it is not actually the trigeminal. Choosing between the ablative and physiological procedure. MBD is a physiological procedure. Microvascular decompression is a physiological procedure where there will be no loss of sensations. So the young patient, I will prefer doing a MBD because I don't want any loss of sensation. As well, it is a long-term relief. Okay, but the problem is that there will be a lot of patients who do not want surgery or who have not benefited from surgery or don't wish to go for surgery. Like a young male who is 22 years and he is not married. If you tell him to go for MVD, he will say, my marriage will not happen. कोई बोलेगा यार ब्रेन की सर्जरी करा के बैठा हुआ है शादी. So there are patients who have come to me at that young age, got a RFA done 5-6 years down the lane after getting marriage, again coming back for RFA. And at that time we can go for MVD. RFA करने के बाद भी MVD करा सकते हो, ऐसा नहीं है कि MVD हो नहीं सकती. So radio frequency rhizotomy is the procedure of choice when medications fail and surgical treatment is considered unsafe. MVD age itself is not a reason to reject MVD. Previously there was a cut line of 55 years. Now there is no age limit. I say that even surgery at 75 is a good option if patient is okay. Many patients 75 years and old also tolerate this procedure extremely well. Microvascular decompression of the cranial nerve 5 is recommended for healthy patients, those with isolated pain in the first ophthalmic trigeminal distribution or in all the 3 trigeminal distribution, or patients who desire no sensory deficit. Okay, so this is not my forte, this is neurosurgeon's forte. But what I do is I will discuss So this is a case of secondary trigeminal. A patient was having a schwannoma surgery 4 years back, had good relief. Since she is a doctor herself, okay, working in BHEL. So since past year, there was recurrence of pain. So somebody advised her to go for gamma knife surgery. And after that, pain was still not there. So surgeon and the patients were reluctant for repeat surgery. So the patient came to me, and these are the 3 ablative procedures. Gamma knife is also ablative procedure. But you will be astonished to know that gamma knife has the least success rate when it comes to, if we compare these 3. Gamma knife success rate is 75 to 80%. Coming to radio frequency ablation, the success rate is 95%. Gamma knife is expensive procedure. Radio frequency ablation is not that expensive also. So don't choose gamma knife over RFA. I don't feel the literature even supports it. So what we do is we go to the foramen ovale. We identify the foramen ovale under fluoroscopy guidance. Okay, we put the needle through foramen ovale, and we insert the needle and go up to the Gasserian ganglion. This is the ganglion through which the 3 roots, the V1, V2, and V3 will originate. And this is how I put the needle, and percutaneous Gasserian ganglion. And so this is the neurovascular conflict. Okay, so you can see there is a Fiesta scan which we order usually to see this conflict. Most of the times in trigeminal neuralgia, around 80% of the patients, Fiesta scan will show some vascular loop of AICA or ICA, which is compressing the trigeminal nerve. One picture is not clear, but anyways, so when we do a surgery, I put some cotton or Teflon between these 2 because they don't touch each other. Okay, when they are apart, the pain will go away. But putting this at the right place is the most important step. If it doesn't work, then fluoroscopy guided submental oblique view, identify the foramen ovale, put a needle, go till the base of skull, clivus petrous junction, and then ablate the nerve. Patient will be conscious. You will stimulate the nerve. Patient will say, I am having the pain in the same distribution where you are touching. And then you heat the nerve at 70, 80, and 90 degrees Celsius. For 5 minutes, patient will have pain, and then the patient will have numbness. Okay. The pain relief usually occurs after 2 weeks time, not immediately, because initially when you are charring a nerve, the nerve will have some edema and some pain. After 10 to 14 days, patients start having good relief. Now there is a patient who is having an ophthalmic problem or having the 3 nerves involved. In those cases, what we do is a balloon compression rhizotomy, where I put a 14 gauge needle, okay, through the foramen ovale, and then I put a Fogarty. Okay, this is the Fogarty, 4-inch Fogarty I have put, and so then this Fogarty goes through the needle and goes, and then I dilate the balloon. Okay, I put 1 ml of dye so that I'm able to see. This is a pear-shaped balloon which is there, clivus petrous junction in near the brainstem. Okay, so this will compress the nerve and the nerve will become dead. So uska dam घोट रहे हैं, ठीक है? So this is how the balloon will look like when it is inflated inside. So when this is the last slide. Okay. This is how foramen ovale is identified. You go inside. Okay, you put the 14 gauge needle. You put the Fogarty. The CSF sometimes comes. Okay, so this is how the CSF comes, and then you start inflating the balloon. Okay, this is the pear-shaped balloon which comes, and for 4 minutes, 3-4 minutes, we inflate. Okay, so the time is to unravel the mysteries of pain and the ways to treat it. And thank you so much for patient listening, and thank you so much, Dr. Pankaj, for this opportunity. Thank you, sir. Thank you so much.
Thank you for completing the session in time and enlightening clinicians about the pain management other than the medication. So I just want to have 2 questions.
Yes, sir.
I just said you give steroid blocks in the post-hepatic neuralgia. So can't steroids already be used in the acute phase so that inflammation becomes less and later on the pain becomes less? Number 1. Secondly, the balloon versus the RFA rhizotomy. So what is in your experience, which is better? Okay. Because balloon is you are pressing and making it nerve, and there you are pulsing the nerve.
Yes, sir.
So what is it?
So, sir, first answer is that whenever people who are not giving block, they usually use steroids in low back pain also. They use in herpes also. But the thing is that when we have a better modality, we can put 20 milligram of steroid. Instead of giving orally steroid you will give at least 16 milligram, 24 milligram per day for some days. Okay, the steroid will spread to everywhere, but the area where I want it, it will be going only 1 to 2%, 3%. But if I have a modality where I can put it, and this is a depot preparation. Depot preparation, the steroid will be there for many days. Even if I have put a steroid and after 1 month the surgeon has opened the case, he can see something, some particles there. So these are particulate steroids and they stay there for long. So the side effect profile is less and the effect is better as compared to oral. But if you don't have a modality, steroids per se, if we give it for 14 days, 21 days, then it will lead to suppression of immunity also. So I feel that using lower doses, targeted approach is always better. If you don't have anything, then you can give oral also. Second question is using RFA and balloon. Balloon is usually the choice when I have all the three divisions involved or there is a ophthalmic division involved. The reason is when I do a radiofrequency ablation of the V1 distribution, it leads to corneal anesthesia. So sometimes the wind blows and the dust particle goes inside the eye. Patient will not have any sensation. Patient will rub and will lead to corneal ulcers. This corneal anesthesia is not there when I use balloon. Okay, the duration of effect of RFA is always higher. RFA, the effect in books, it is written 2 to 8 years, and same is my clinical experience that patient usually comes with recurrence of pain after 3-4 years, and after that, if I start giving medications, again 2 years are lapsed. Then after 5-6 years, I can again repeat the procedure. Okay, balloon, the usual effect lasts for 2 years or 3 years. So because it is a neuropraxia which we are doing, okay, neuropraxia, the effect will not last up to 8 years. It will last for up to 2 years or 3 years. But that is a painless procedure because balloon is done under general anesthesia. I don't have to stimulate the nerve and ask the patient whether you are feeling the sensation or not. So there are certain young patients who don't want any painful thing when I do the procedure. 3 nerves involved or ophthalmic division involved, prefer balloon. Otherwise, RFA. Any question? Sir, every time the posterior prolapse is the one which is painful. Anterior prolapse, no symptoms. Anterior prolapse, there is no spinal cord, no? The cord is behind. Acha, posterior versus lateral. Okay. So posterior is, you mean to say central disc. Okay. So central disc, usually the pain is usually not radiating. Mostly patient will have pain in the sitting position, standing or forward bending. The lateral, mostly there will be sciatica. The interventions, usually when it is an axial distribution of pain, the interventions don't work that great. Okay. Interventions work better when there is a sciatica, this epidural. If the patient is only having axial pain, I am usually guarded by my prognosis कि यार पता नहीं, क्योंकि axial के अंदर इतना अच्छा relief नहीं मिलेगा, तो जो books में करते हैं या मैं कुछ patients में करता हूँ, that is baculoplasty. Baculoplasty is one where I usually ablate the sinovertebral nerve, which is supplying the posterior annulus. But it is an invasive procedure. I don't want to enter the disc because disc is like a temple. If there is some infection in the disc, it is very problematic for the patient. It is like screwing the life of the patient. So I am very conservative in my approach if I have to enter the disc. But if patient's pain is really bad, then you can, first my choice will remain the same, epidural steroid. If it is not getting better and patient's life is hell, then we can go for baculoplasty.
Question from the subcutaneous Botox and for that.
Sir, I have not used, but I will like your opinion because I have seen people in Max Saket putting Botox and then those patients are coming to me with less relief or maybe after 2-3 months again having pain. So I usually don't think that Botox works for that great. And only two indications where Botox works is, one is migraine and one is equinus or some spasticity. These are the two indications where I use Botox. Yes, sir. But I don't know whether it works because my clinical experience in trigeminal is not. Even books have not given it as a level 1B, 1A indication, because sometimes we are using those interventions what we have. Yes.
Patients who are not willing for microvascular decompression or radiofrequency ablation, role of steroids in patients, the role of Botox in patients with TN or post-herpetic neuralgia, and the amount of relief that they get, because a lot of patients are not willing for ablation or surgery.
Yeah, the same question. I'm just saying that usually the relief is very short lasting, even if it is there. Even see, I go by literature. Okay, when literature says Botox doesn't work or works in very small quantity of patients, short lasting relief, Botox cost will be 20,000 rupees. Okay, you will put at least 100 units of Botox. 100 यूनिट ऑफ बोटॉक्स 12,000 14,000 रुपए का तो बोटॉक्स आएगा, 3 महीने के लिए रिलीफ मिलेगा, पेशेंट को जिंदगी भर की प्रॉब्लम है, कम से कम कुछ सालों का तो रिलीफ देना चाहिए.
Patient who started on steroids along with antivirals. So giving that injection in the initial phase is recommended, or we initially give a trial of steroids and after that if it doesn't work, then we
so every time whatever book says, we don't follow that. Logically speaking, most of the times acute herpes neuralgia can easily be managed by medications. When it is PHN, we go for interventions. Unnecessarily poking the patient is of no use. Yeah, we can give it for 4-5 days because the inflammation is that much that if it is not subsiding with NSAIDs, then only we'll go with steroids.
In experience, we use that. We found better results. Thank you.
Thank you, sir. Thank you, sir. Sorry.
The posterior herniation of the disc, I mean, there are symptoms. So is there any MRI criteria or any imaging criteria which can tell you or guide you that this patient will get better with physiotherapy or medical intervention versus this patient will require a surgical intervention? For example, the disc herniation is more than 1/3 of its volume. That's number one. Anything that can help you to guide on whether this patient would eventually need a surgery. Second question is this degeneration. Is there any way or any medical intervention which will prevent this degeneration with age?
Okay, sir, okay. So the first question is that the size of the disc doesn't tell about the symptoms. Okay, any minor disc, 1 or 2 mm of disc bulge in the foramen itself can cause excruciating pain and difficulty in walking. Sometimes even an extruded disc, a disc which has broken and it is lying in the canal, is not causing any symptoms. So size of the disc doesn't tell us about the symptoms. Sometimes patient is having right-sided disc and pain on the left side. Okay, so this is very, very common. But there are criteria where we can suggest that this patient will not require surgery. A diffuse disc bulge. Okay, patient is having pain in the both legs. Usually diffuse disc bulge, what surgeon will do? Surgeon will not be able to remove that small diffuse disc bulge. Only if it is extruded, protruded portion, surgeon will be able to help you out. If it is an annular tear, what will the surgeon do? Nothing he can do. So there is MRI you can read and you can tell whether surgery will be of help or not. Because I was a neuroanesthetist day in and day out for 15 years, I was seeing that also. I am able to say कि उनके कितने patient ठीक होते हैं कितने नहीं. Okay? And there are problems with surgery as well. Adjacent level disc disease, epidural fibrosis. Patients come after 1 year with recurrence of pain. Okay, so definitely there are MRI features which an experienced person can tell whether this patient will get better or not, but it will require some experience. Lumbar canal stenosis, it will not get better with time. It will definitely require a laminectomy surgery if the neurological complication is there and pregabalin is not working. Intervention is only a choice delaying the symptoms, so it is not a very good option. Okay. And the second question which you asked was disc degeneration. Only thing is exercise. Okay, आप उसको compress expand करोगे, उसका vascular supply अच्छी रहेगी. So thank you.
I request the chairpersons to please felicitate Dr. Anura. Sorry. Lalit sir.
I don't have a camera.
I request Dr. Pankaj to felicitate Dr. Lalit and Dr. BK. So our next case is an interesting case of recurrent abdominal pain with neutropenia. Dr. Sohan Biswas, second year DNB resident from Max Hospital, Vaishali, is going to be the presenter. The case is going to be moderated by Dr. Pankaj Nanchaudhary, and it is going to be chaired by Dr. RPS Makkad and Dr. Rohit Kapoor, who is consultant pediatric hematology and oncology, Max Vaishali. I request Dr. Sohan to start with the presentation.
Dr. Sohan has gone to for examination of FAT, foundation suspended examination of DNB. So I think he can't be here. So I'll be presenting this case. So as usual, we are going to present a very simple and very difficult case altogether. Sometimes it feels very easy, and sometimes it comes very difficult, right? So yesterday we met Dr. Makkad. So I said, Dr. Makkad said, what case you are presenting? So I said, okay, young patient, young female coming with recurrent abdominal pain. So he said, acute intermittent porphyria. I'm like, yes, but no, it is not there. It's not the diagnosis. So I think we should learn, and I'm very fortunate that I'm here in the corporate hospital where everything is available so that we can have consult with the other departments. So yes, right. Okay. Right. So interesting case of recurrent abdominal pain with neutropenia. So I'll just go by the case. This is patient 26 years of female. She is a bank employee by occupation, a resident of Greater Noida, UP. And BMI is around 19.5. So she was admitted by 23rd of September with this presenting complaints of severe upper abdominal pain, multiple episodes of vomitings, patient not taking to take orally. There was no fever and there was no stool. On examination, patient seemed very dehydrated and blood pressure was around 80/60. So definite diagnosis was acute gastroenteritis on September and August, September. A lot of patients of food poisoning that used to come and patient treated with then just fluids, and patient got better. So we admitted in the patient in the ward after initial resuscitation. So after initial resuscitation of fluids, the patient got better, blood pressure went up, and we saw that patient having severe gastritis. So we gave PPI infusions, fluids and support management. So this was this labs on day 1. Hemoglobin was 8.7, and platelet was normal. TLC was on the lower side, 3.89. The neutrophils was around 50%. It's not being mentioned. CRP was 59. So there's some information is going on. On next day, we repeated hemoglobin, came up 9.6. Neutrophil was 40%. And if you see the ANC, it is 3.08. Rohit is there with the methodology. So how you calculate this absolute neutrophil count? So when we get the CBC, how you calculate? It's a very common question that we ask, right, generally. And we don't calculate ANC as well. Right?
So actually, we take the total TLC, we see the percentage of the differentials, and we then try to see whether the patient has mild neutropenia, moderate neutropenia, severe neutropenia, or profound neutropenia.
Right.
So the things start when the ANC is less than 1.5. Okay, so between 1 to 1.5 it is mild, between 500 to 1000 moderate, severe is less than 500, profound is less than 300.
So absolute severe neutropenia would be when the absolute neutrophil count is less than 500.
Yes.
Right. Welcome, Dr. Vijay, sir, scientific chair of Israel Physician Association. So we have just started the case and we just finished the first case. So this is though this afternoon count is 3.08. I think it's fine. 3,000 is also okay, but neutrophil is 40%, is on the lesser side. So she was discharged, right? She was discharged on I think 30th of September. Again on 13th of October, again the patient developed same symptoms, right? So patient came with fever, 103 degree Fahrenheit, multiple episodes of vomitings, upper abdominal pain, amebic orally. So there was some oral ulcers as well, and cough and some shortness of breath. And when we examined the patient on ER, she was severe dehydrated. Patient BP was around 70 systolic. So we need to admit the patient said that patient is having sepsis, and patient was shifted to ICU and put on IV broad spectrum antibiotics, NIV support with oxygen, and some vasopressor was started. Patient was actually this time was a little sick looking, right? So we just took the history. So she had some recurrent abdominal pain for some time, maybe a few months, and for that she went to Ganganam Hospital as well. She showed there to some gastroenterologist. She was prescribed some medication, some treatment, some investigation, but the patient was not carrying any records. So they said a patient having some recurrent oral ulcers, right? So recurrent oral ulcer with this picture, we would see some autoimmune, some phenomena going on must be. So this time the patient was sick and the patient was in ICU, and young patient with no diagnosis, where is the sepsis? This was the report on 13th when the patient came, hemoglobin 10.4. TLC was still, because when we discharged patient was 3.8 TLC, leukopenia. Well, TLC gone further, went down further. It was 2.5, and to our surprise, the neutrophils were only 6%. Only 6% neutrophils, and there were some metamyelocytes. 31% I think was monocytes, and around 60% were lymphocytes. So we are quite curious. And again, on there, the TLC, the neutrophils again gone down 2%. And ANC was just 0.04. So it is severe neutropenia, profound neutropenia by definition, right? So platelet total leukocyte count was 1,900. So we were just puzzled at what is going on to this patient, right? So we just got further investigation to cause secondary infections, and we found that dengue was positive, IgM was positive, though platelets were not gone down. Brucella IgM, IgG positive. I don't know what is Brucella, because there's no history of some milk and otherwise, but Brucella was positive. Procalc was high, it was 9.43. Liver functions, kidney functions were all normal. Cultures, urine and blood culture were all sterile. And we did the HRCT because X-ray shows some haziness, certain haziness in the both. So we got CT done, and CT done shows bilateral low pneumonia.
Why Brucella antigen was sent?
Nini, right?
Why Brucella antigen was sent?
So right, why Brucella antigen sent? Because patient was having recurrent this fevers for I think was having some fevers.
On the PO.
Yeah, not PO, because patient got better also, right? But patient was getting the recurrent fever, recurrent abdominal pain. So just on the safe side, we just send, when we don't find any organism, we send Brucella, lepto, scrub, everything was sent, right? So we're not suspecting any Brucella in this patient, but it was sent as a protocol, like, okay, fever, are a recurrent fever, so send. So, but dengue came out positive, but sir, it was not negative. So I just kept the most of the positive markers. We did not test like LDH and everything we did, but I'm just want to keep the positive. So this viral markers, this NPSAG, SCV, and HIV are all negative. Right, I'll just come to later on that when the CT was having some pneumonias, stool OB was positive because patient had low hemoglobin. So stool OB was positive in that sense. So this was the time that hemoglobin is 8.1. TLC came down further. Right? Now it is 1,000 only. Neutrophils again 2%, and with 64% lymphocytes and 3%. Welcome, Dr. Gupta, Vice President, sir. So we did a PS purple smear. It's not maxotic, normocytic. TLC was decreased with severe neutropenia. So the differentials now comes to our mind. Right. Okay. So are we dealing some autoimmune phenomena? Like, are we dealing with autoimmune phenomena? And we discussed with hematologist colleague. They said there is an entity which is called as autoimmune neutropenia. So autoimmune neutropenia, and require treatment, they get better off. But so neutropenia, they get secondary infection. In adults, most of the time they are secondary to some other illnesses, some other autoimmune phenomena. So we just screen all this autoimmune phenomena as well. We did the ANA came out to be negative, right? Okay. So the patient was managed with this meropenem, the sticoplanin, we added antifungals also, right? The patient's knee got better. She was off vasopressors. Her TLC start improving a little bit, but the patient had a recurrent neutropenia. So we took the this advice from our hematologist colleague. Dr. Rohit is there to plan for a marrow. I think. So I think Dr. Rohit, we should plan a marrow. Yes. Any autoimmune from now, because autoimmune neutropenia we have heard it is a known entity where autoimmune process goes to neutropenia, and they're mostly secondary to some autoimmune pathology. Like I think this as a young patient, but they don't have any marker, no rash. Okay, so we took the and I think this we should plan. Other lineages are normal, like platelets are okay, right? Other only neutrophils, neutropenia.
We did see the marrow in the microscope itself when we went downstairs. Basically, we, as sir said, actually the hemoglobin precursors, the RBC precursors were okay, the platelet precursors were okay, but there was myeloid maturation arrest. Now, what really happened? We thought that the myeloid maturation arrest will lead to some autoimmune phenomena, but we already ruled out. We did a screening for ANA, we did screening for CNCA, PNCA, ENA profile, all these things. They were all negative. All the antibodies were negative. So there was myeloid maturation arrest, but we didn't know what exactly is causing the myeloid maturation arrest, and we ruled out all the acquired causes. So then there were excessive granulated precursors within the marrow. They were not released. They were just sticking in the marrow and they were not actually released. So peripheral neutropenia with increased myeloid precursors can be due to certain disorders, which we'll discuss as we
right.
Go.
Okay, so the occurred but positive. We just try to rule out there is some upper GI bleed. So gastroenterology was taken and they advised upper GI endoscopy, which suggestive of healed gastric ulcer. There could be fungal. So some gastritis was there. So it could be fungal because definitely neutropenia there. So there could be secondary fungal infection. So biopsy showed microtic chronic gastritis. So we added antifungals as well as CT abdomen and chest showed that biotic consolidation of the lower lobe. The patient got better and ANC from 0.02, it gone up to 2.04, getting better. So this we take the hematology reference, and I think this bone marrow was done. The bone marrow aspirate showed the dimorphic anemia with leukopenia, severe neutropenia, left shift of myeloid maturation and reactive changes. Like neutrophils were 2, 64% lymphocytes, monocytes 30%, and myelocytes are 3%, and 4% blast with myeloid arrest. This was the report which came to us.
There was no leukemia. Actually, there was no MDS. We thought that it can be just an MDS.
Myelodysplastic syndrome.
Myelodysplastic syndrome, like the thing, but there was no hypothalamus. There was no abnormality of the nucleus or nuclear line or those things. But there was increased precursors actually, and there was no evidence of any leukemia or MDS.
Right. So bone marrow biopsy revealed normocellular for age, showing trilineage hematopoiesis is important. With left shift, myeloid maturation, excess macrophages, predominance of eosinophil precursors, excess of macrophages. And acute leukemia apparent side was negative actually. And ANA, as I already told you, it came out to be negative, and RF2 was also negative, and anti-IgA, DGP, IgG all were negative. But there was no immunoglobulin deficiency as well. So we are in just sure at what is actually happening. I think she was a vegetarian. So persistent leukopenia, also history of recurrent oral ulcers. These were the reports. So ANC got better from 3.55 to 8.36 to 8.66. The patient got better. Abdominal pain got better. He was out of ICUs and shifted to ward. And we just saw that is there any benefit of this GCSF for this patient, because patient is having severe neutropenia. So I think we gave that one injections of this fengastrine to her of 300 micrograms subcutaneous, and we started on cyclosporin and dexamethasone in view of autoimmune neutropenia. We did not actually diagnose as autoimmune neutropenia, but in the benefit of we started this treatment.
Yes, sir. The EMT were not available, but she was so profoundly neutropenic that we could not have just relied on just one GCSF injection, right? So we wanted, we gave a trial of dexamethasone with a broad spectrum antifungal, broad spectrum antiviral cover, and we started on cyclosporin to see any autoimmune neutropenia and maturation arrest that can be taken care of by cyclosporin. There were still other options like azathioprine, and there are other options for these things like MMF, azathioprine. All the options are there, but the thing is, we first tried cyclosporin because it was easily available, and azathioprine could also cause anemia and thrombocytopenia. So that some maturation arrest can be tightened over and some cells be released in the circulation.
And meanwhile,
It's safe to start cyclosporin on such vision.
So actually, the main thing is cyclosporin under a broad spectrum. So actually, the pathophysiology which was underlying the marrow was maturation arrest. Okay, so sometimes there are certain unknown molecular things that can be some autoantibodies which are not easily detected by DNA panel, DNA profile, or certain major tests that we are not aware of, which may be causing.
बड़े हिम्मत चाहिए.
right. Sort of just
So
it's a very difficult case, I must say. There are certain things. Why are we only thinking of autoimmune? Why can't we think of some severe viral infection?
Yes, yes.
Bilateral pneumonitis.
Yes.
But respiratory biopsy.
Dengue
Yes.
positive.
Dengue was positive. And the procal was very high.
Yes.
That again wasn't.
So this comes out into the second infection. But primary event is neutropenia. Event of neutropenia 1% because sepsis doesn't got. Because sepsis, I could say, yes, but this patients have a recurrent neutropenia. I'm not talking about patient comes with sepsis, we correct it all the way. So this is the second admission, and there was some history in the past also we don't aware of. Patient have a recurrent abdomen. Three to 4 weeks time. So because the patient is coming, getting better, the trigger should be only once, not repeated. Repeated. सर लिश्मानी की बात नहीं हुई थी, लेकिन कुछ पेशेंट हमने सस्पेक्ट किए थे कभी कभी, लेकिन फॉर टाइम को कई किसी निकला नहीं.
Was an ID consult taken at any time? ID consult taken?
Sir, we are all ID spaces, sir. But we must agree that we can. No. Yes, sir. Soachenge sir isko. The problem is that there is some. We just reviewed the literature, and we just felt that there are some genetic testings are also available. So meanwhile, when we started the bone marrow, we sent the genetic testing also. Okay, we are missing some diagnosis, but the issue with genetic testing, it used to come after 2 weeks time, and patients are actually with us. So for 2 weeks, we can't hold the patient for 2 weeks. The genetic testing come, and then we start the treatment.
Whole genome sequencing?
And NGS, sir.
NGS?
Yes. We send NGS.
What about can any patient do BO? Should we try this Lexa combination?
No, sir. No, sir. Sir, this is because of profound neutropenia leading to sepsis, and they are recurrent. Actually, the symptoms are recurrent. Actually, for 4 to 5 times, the symptoms are recurrent. So first time the patient was very sick. Actually, she was very sick, young female patient, admitted in ICU with no diagnosis in her hands. You can understand what the trauma the patients do everything to us. We should give the benefit of doubt and
Medically, are we safe? If we start with this type of medical,
sir, I'm going to tell you one thing.
Dr. Kaur,
Yes.
Sir, medically,
Yes, sir. So just one thing, I sorry, sir. I want to tell one example, then we can extrapolate to this case.
yes.
Actually, there was one patient, actually I presented recently, and this patient, but was a adult male. Dr. Sumer remembers this patient.
Dr. Sumer, okay.
He is not here actually. So this patient was an elderly male, and he was admitted, and he had severe neutropenia in one admission, had LRTI. Okay, and once his infection subsided, his neutropenia, it improved. He again had an episode of LRTI. He was 59 years old male. So again, he had neutropenia, but rest of the cell lines were absolutely okay. Did a marrow. Again, it showed some mild maturation arrest. He's an elderly male, and history of smoking, alcohol was also there. Okay, so in that again there was mild maturation arrest, and his ANA was also negative. So again, but rest of the cell lines were absolutely okay, and we ruled out MPS. Okay, so because the maturation arrest, but all the antibodies were negative, we did a trial of cyclosporin as well as the dexamethasone, and his neutropenia improved. This case actually presented.
But in that case, recurrent bone marrow were done.
No, it's only one bone marrow itself. So only one marrow was done, and this was a second episode of LRTI. So we never knew that there are certain unknown antibodies that were interfering with the release of the the neutrophil from the the marrow, and they were not and the patient, because the patient was neutropenic, had recurrent LRTI and all these things. So sometimes cyclosporin inhibits some T cells that sometimes affect the maturation or the release of the cells from the marrow to the circulation, and that would increase the neutrophil count, and the patient can die over the infection. So that's what probably
Serious people here. We must reach the conclusion. What exactly was there? Maturation arrest.
maturation arrest sometimes can be taken care of by steroids as well as some cyclosporin that can release the neutrophils, and that can tide over the
That's
active
what we
infection.
want to
Yes,
say.
sir.
So that's a way given.
Yes.
And we not negative cyclosporin.
Yes.
But
Fantastic, sir.
no.
The test rate traction were fine. Ferritin was not that fine.
No antibodies.
बाद में add करिए.
Yes, बाद में add करिए. It's something add करिए.
Right.
So
So patient got better. On 23rd of October, you can see hemoglobin 9.8, TFC was around 10,000, neutrophil 48.4%, and ANC was around 6,000. So I think patient got improved by all this phenomena. Whether she responded to steroid. She responded to steroids. She responded to cyclosporin. She responded with sepsis treatment that antibiotics and all that. We don't know. But actually, we are waiting for this this next generation sequencing that we did send it. It took almost 2 weeks time, and by the time the report came of this NSG, patient also came.
yes, sir.
Patient also came with. The patient got admitted on the same day the report came, right? So, but actually, the patient received this pegylated granulocyte stimulating factor a day before, and patient had fever. So sometimes this pegylated can cause fever also. So patient was actually admitted. Patient CBC was okay, not that neutropenia. Patient was managed conservatively, and we thought it is because of the side effect of this pegylated this granulocyte factor. Then she was discharged next day, right, without any issues. So there were 4 admissions in the span of these 2 to 3 months, right? And if you could see this report. This you can see, right? So this is the chart actually we made, right, from my data. That this is first, the upper one is from TLC. So it is normal, then again goes to leukopenia, again went up, then again went down. So some type of cyclical phenomenon is going on. And this cyclical phenomenon is seen in the neutrophils also, right? It is going peak to trough, right, in the span of 3 months, right? So this we could pick out, and the patient actually has regular follow-up, nobody as well. After 2 weeks time, she come up with the CBC report. So we have charted everything. So you can see some cyclic phenomena going on. TLC is going up, down, neutrophils going up and down. So something going on, and we got this report of this gene.
One thing more, where is the role of dengue IgM and Brucella IgM in this case?
We don't know.
Because reacting antibody.
Yes. So there are a lot of Brucella positive than this. Yes, we have given doxycycline. हमने रिफेम्पसिन दे दिया सर, हमने रिफेम्पसिन दे दिया, हमने डॉक्सीसाइक्लिन दे दिया, हमने सबको दे दिया सर. राइट राइट. सो आगे चलते हैं हम लोग. तो थिंग राइट. So angiography, why is having abdominal pain? So CT angiography showed us diffuse neurothickening and enhancement the long distal ileum, and which is with mild free fluid in pelvis, suggestive of some underlying